Now we have Dr. MARIAN PAULY madam. She's a senior consultant oculoplastic surgeon at Giridhar Eye Institute. She'll be sharing some rare case scenarios.
Thank you. Good afternoon. At the outset, let me thank Saumi and Shebin for giving me this opportunity. So we have listened to both Dr. Saumi and Dr. Abanna regarding some common things and the common threads. So I'm just presenting some rare scenarios, but they present like a common thing, but turned out to be little rare thing. So my first case is an 8-year-old child presented to us with occasional diplopia following a vague trauma. So this was the clinical picture. You can see the globe is displaced down and there is a gross fullness in the superior quadrant of the left eye. Now look at the scan. The scan, we can see a well-defined mass in the superior quadrant. The radiologist reported it as hemangioma, and the ophthalmologist or the concerned doctor treated with oral propranolol. So now the question comes, is it hemangioma? Should I continue the oral propranolol? Let us see one more case. The histopathology turned out to be rhabdomyosarcoma. I'll speak later. So this is another child, 9 years. Again, history of vague trauma. Came with a grandmother because parents are abroad. With a swelling in the left eye of 2 weeks duration. And the CT scan showed a mass in the superior quadrant. You can see it is actually involving the superior rectus, but rest all orbit is normal. Here also the radiologist reported as hemangioma, and MRI was also done since we had a confusion. So MRI also reported as hemangioma. But see, there are two things in this. Hemangioma usually occurs in histopathology was rhabdomyosarcoma. Now we'll see how a hemangioma looks like. A hemangioma usually starts at 3 weeks of life, like within 1 month, and it gradually progresses and reaches by 1 year of age, it reaches its maximum size and then it gradually starts involuting. So here also you can see one hemangioma. Look at the color of the lesion. Now look at the other two kids. So this is our child 1 and this is our child 2. So how to differentiate? History is very, very important in localizing the pediatric lesions and imaging, of course. So the first picture is a picture of a MRI of a hemangioma where you can see some flow voids like the dark spaces inside the hyperintense lesions. Whereas the second MRI is a case of rhabdomyosarcoma or any other solid mass lesion where it is uniformly solid. So this is one way history and clinical findings and radiology will help you. You cannot blame the radiologist because we are the one who are seeing the patient and we have got a clinical diagnosis. So now coming to another patient. He is an 11-year-old boy presented with a recurrent swelling in the left eye. So you can see there is a minimal fullness in the left eye. Already he was treated by oral antibiotics and NSAIDs before presenting to us. So now look at the scan. So he was advised CT scan and you can see some bone erosions in the temporal wall, lateral wall, and you can see an ill-defined mass in the temporal near the lacrimal gland area. And in this you can see some bone erosion is clearly seen in this picture. So from Dr. Same we saw dumbbell dermoid. So one possibility can be a dumbbell dermoid, but usually dumbbell dermoids rarely presents with inflammation. So I also thought this could be an initial dumbbell dermoid. So however, under frozen section we did biopsy and the biopsy showed inflammatory cells. So we excised as well as we gave intralesional triamcinolone and the child did well on follow-up. So this inflammatory lesions initially presents with cellulitis. Initially always we treat with oral antibiotics. However, imaging will give a clue to the diagnosis. So imaging is important. So there is always a question of debate. MRI versus CT. I prefer CT scan. 2 reasons. One, to get an MRI in a child, you need sedation. For the sedation, you get anesthesia, open a lot of formalities. CT scan is very quick and you get the result in under 30 minutes. But there are few lesions which requires MRI. So the child did well with the treatment, and this is the post-operative picture and follow-up at the last follow-up. So this is another patient, 8-year-old child. From the clinical diagnosis, this is a case of orbital cellulitis or preceptor cellulitis. Already received oral antibiotics before presenting to us. So as a routine, orbital cellulitis always admit and treat. So the child was admitted around 10 a.m. So this was the presentation, at 10 a.m. presentation. Left lid there was mild swelling, but we were also wondering why the swelling in the left eye. So initially we thought some dependent edema. But after 5 to 7 hours, you can see the swelling in the left eye is increasing. Right eye also the erythema has increased. Meanwhile, the duty doctor also told there are some rashes in the hand. So then really we got confused. This is not a normal cellulitis, this is some atypical cellulitis. So we did an immune workup because already the child had routine blood, etc. when they came to us. So we did immune workup and the anti-nuclear antibody was positive. The child was referred to pediatric rheumatologist, and the baby had end-stage renal disease, and she was given dialysis in the same week itself. So admitting and monitoring an orbital atypical cellulitis is always very, very important, especially in diagnosing some rare instances like this. Periocular diarrhea we have already seen, but the presentations can vary in like different ways. And especially in pediatric, it's literally very difficult to diagnose and sometimes to get a diagnosis as well as to treat also. Because to convince the parents, we have to be like, they will ask you whether the child will get parasite. So this is a child who presented with a recurrent lid edema, and you can see a nodule in the temporal part, and here no need to go for any MRI or CT because it is confined to the lid. Rest of the eye is perfectly normal. A simple ultrasound of 5 minutes will give you the diagnosis as parasitic cyst, and treatment is excision of the mass. Second thing, this is a 1-year-old child, again presented with the initially inflammation, then presented with a nodule. So this also turned out to be a parasite, and here also parasite. So how to differentiate between an infective cellulitis and a periocular parasitosis, because parasite is very common now. One history, they always give a fleeting edema. Yesterday it was okay, today it is more. Cellulitis usually it increases. Most of the time without treatment it increases. Parasite usually it is like ups and downs, fleeting edema. And second thing, in cellulitis, usually kids are little toxic. They have fever, not able to take food properly, etc. But here the child will be like perfectly normal except for the mild swelling, and ultrasound will give the clue. Whereas in cellulitis, you have to go for CT or MRI to assess associated sinusitis, etc. So differentiating an infective cellulitis versus a parasite is very, very important in the management. Now coming to another patient, she is a 7-year-old presented with a swelling since 3 weeks. So you can see there is a definite swelling in the left eye. So we did a CT scan. It showed inflammation in the temporal quadrant involving the lacrimal gland. And the most important thing is that mass is indenting the globe. So in this case, you cannot, any mass that is indenting the globe is not a regular inflammation. So we did a biopsy with the debulking and showed it as granulomatous inflammation. Then child was referred to a rheumatologist and started on steroids. So here also imaging gives the clue. Now coming to ligneous conjunctivitis. This is looks like a vernal, but this is very, very difficult condition to treat. We use cyclosporin drops, then excision, amniotic membrane, still it will recur. So ligneous conjunctivitis also it's a little rare, but it's very difficult to treat also, but we have to diagnose. So coming to the last case, the 13-year-old girl presented with a recurrent lid mass since 3 years. Because before the child presenting to us, she had already undergone 2 INCs. So that is why they presented to us. Now look at the character of this mass. So if you see there is an area of loss of flashes. The lid margin is not very well defined. You cannot see the meibomian gland orifice, but the tarsal area is perfectly normal. So initially, I have not seen such case in a pediatric. So I was also like clinically, I didn't have any diagnosis. But one thing I know, it is not a malignant tumor. So whatever it is, under frozen section guidance, we took the child, and the frozen section itself showed it was a benign tumor, and the final biopsy report was granular cell tumor. That's a tumor that arises from the neural sheath, and complete excision was done in the form of wedge resection. So this is also, so rare findings will give a rare diagnosis. So that is one thing that we have to keep in mind. So to conclude, history is very, very important, but in pediatric age group, it can be very misleading also. So you have to correlate with the clinical findings to reach a diagnosis. Imaging depending on the scenario, biopsy in relevant cases, and excellent outcome in most of the cases. Thank you so much.
Thank you, Dr. Marian, for their elaborative